I'll just do my final thing.
Yeah.
Okay. Hello. Can everyone in Lincoln hear me as well? Can someone just pop up their hands or give me a?
Yeah, we can.
Yeah. Hi. So I don't know if you can see me. Hi. I'm one of the clinical teaching fellows with the undergraduate medical department. Before you start your IMT teaching, I just want to do a 5 minutes of intervention. I am doing a radiology audit. So it's about assessing your referral guidelines in terms of radiology. Do you guys know that you have guidance available for various scans that you can actually look for? Any idea about this? Any response from Lincoln? Do you guys know that there are radiology guidance available to you guys on the intranet?
No,
No.
No?
no. I'm only if it's already in an existing pathway that I'm looking up.
Okay,
For,
so
for like PE, query PE, and then it's like order CTPA. That's the only time where I feel like.
yeah, so that's what you guys refer. So you go through the list of like the disease and then which investigation is requested. So if you ever come across something like that and you're not sure if it's something like not a PE, which you know has to go for a CTPA, and you have to do some other sort of investigations. So you have something that's called as iRefer, which is available on the intranet. So if you go on to ULSG links, web-based applications, and go to I, which will be this page. And once you log in or register, this is the page that comes up. So that gives you all of the guidelines that's available in terms of any investigation that you have to request. So if it's example is a community acquired chest infection. So when the X-ray is indicated, ultrasound, CT, and you have different comments that gives you a guideline as to whether that will actually work or not. And you have different categories on the left side as well. So it's adults or pediatric. So depending on that, the guidelines over here will change. Okay, so if you have a list of conditions to go through, and hopefully they should give you easily a guideline which should, like, if you are not sure which to request for, which will be the right investigations, then you can refer this. Okay, and in terms of vetting the scan also, it becomes easier. If you, after requesting it, you can tell the radiologist that this was according to the guidelines that was mentioned, and it's available on the iRefer, and iRefer is according to the NICE guidelines, which is available. Okay, and the trust actually pays for this to be available to everyone on the intranet. So I hope you can utilize this.
Mine's really not.
Yep.
Well, this is for children that we're looking at.
So in here you have pediatrics and adults. If you click on that, it will change.
Looking at adults.
Yeah, adult. So this right now is
Pediatrics.
yeah. So you have different. So you have the children. So that you have to update the update again.
Search.
So
Okay.
and then adult. And then you have subcategories here as well, oncology, and it will change.
So does that mean if I want to, do you mind explaining how I can use this in clinical terms? Of course, I'm just thinking. And I think if I think somebody else, let's say, features of COPD or reconstructive airways,
Yeah.
it's short breaths, but there's no diagnosis of COPD or the likes before, right? And I want to rationalize it. I might think, oh, let me see a CT scan for emphysematos changes. So,
So if you read the comments here, so they've written in the comments most of the time, look at this, suppose for an MRI,
so you need the arrow to show it.
in the comments, you'll have to actually enlarge the screen and read it. So contrast enhanced MRI, CT, and upper GI studies may help to demonstrate retropharyngeal masses, abscess, or a vascular lung ring. So like if you read the comments, it gives you exactly what features it might show up. So if you're looking for something specific, the recommendation and the comments will give you an idea. Am I answering your question?
No, but I think it's because I'm not asking it correctly.
So if you have a look at the guidelines, this is coming up. I think it has to load up. This can like refresh the thing. Initially, it was coming up for adults. Now it's changed.
Well, IMT there, so most likely.
Yeah.
So filter, I guess.
Yeah, filter.
Okay, so let's see GI systems, for example. Down, that's down. I don't.
Wait. You want to go for GI system?
Yeah.
This is showing up for children. I don't know why this is doing this. I'm really sorry.
I'm going to scroll up on the left, then click adults,
Yeah.
then filter, then GI, that'll be it.
So they do not have a match for me because I have not logged into the email with my trust thing.
Okay.
Once you log into yours, you can see a paid version of this, which will give you an idea. Okay.
Mhm.
But all the common diseases, like I showed you, is available on the front page. And this is one of the guidelines that is the trust provides. Like, I think I've written on breast before. So this is one of the things that the trust provides now. Okay. That will be useful, but then I'm just doing an audit to see if this sort of guidelines is accessible to you guys and whether it will be useful or you need something better. Okay. So the audit is based whether any imaging guidelines are available or not.
To answer your question,
Yeah.
I speak for myself at this wonderful place. We do not know it exists before now.
Yeah.
So now we know.
Yeah.
But then the second, yeah. Well, now the second part of the question, you said, do we know it exists? No. But the other part is how do we use it? Is well, we don't know how to, because and I'll speak for myself, is you investigate, you request an investigation when we're looking for something, like you have a diagnosis or possible diagnosis, then you investigate. So like, it's not like we're generally screening. So like, for example, now if I'm doing a CT abdomen for a person, before I think of a CT abdomen, I have a reason for what I'm doing. So I don't know like what I would check in the guideline, because then it looks like I'm working backward from a diagnosis to go and look for how to screen. But instead, I do the proper way. I think the assumption is you have a diagnosis before you screen, not you screen to look and then be trying to get. So I don't know. That's why I'm saying. Yeah, so that's usually the same thing. I think this is having a problem right now. This is not how it was working on my computer. All of the conditions will show up. So initially you'll have a diagnosis. So you're querying something, that's why you're going for a scan. Yes. So based on like, the first page when it showed up community acquired pneumonia, if you remember. So in that you had X-ray, CT scans. And if you read the comment, it will show up which one is indicated at which part. Okay, so based on that, it will give you an idea whether to go for an X-ray. If you're suspecting a low-grade pneumonia,
then X-ray might be enough, and you don't have to be like rescan the patient again after 6 weeks. So you get an idea whether that is required or not.
Okay.
So this is basically the IRFA guidelines, which is just radiology guidelines available, and not a lot of people are aware. So the first part of my audit was to just check whether any sort of guidelines is available to anybody, but no one was aware about anything. And then this is my intervention sort of saying that IRFA is the basics that's available.
Okay.
And because I won't be doing intervention everywhere, it's just this intervention in all of the teachings for junior doctors. And then we're sort of doing a re-audit to see what sort of other imaging modalities or anything else that's you guys wanted. Do you want it like a pop-up on WebView before you request so that you can go and re-refer the guidelines, something like that? So I do have a QR code if you can give me feedback in 2 minutes.
Oh, we'll be very happy to.
Thank you.
I think we do it exist. After good audit.
It's when you can challenge it.
It's Dr. It's not show up on your.
CTPA. PJ, make content. CTPA for everyone.
Is it not showing up on your? So just have a look. Once you log into the iRefer account, you'll have a list of conditions, and then you can see which ones to go for. And once you get used to the system, you'll be able to use.
Yeah, I got it here and maybe a problem.
So can I open your oh, I'll open your email from here if that's okay. Computers are easy.
Yeah.
Medical education.
Yeah. It will literally just take like 1 minute for you to fill out the feedback form. Basically, it's just whether are you comfortable, did you know about IRFA right now, and what sort of radiology SS guidelines would be useful for you guys in the future. Yeah. Doctor, if you can fill it out as well.
Yeah.
There's a fifth question that like if you have we have already spoken to IT department for a pop-up to appear on Wednesday before you refer for any sort of scan, so you can go back and check the guideline whether it's an actual thing that you're actually referring for a certain scan, which is.
Does everyone automatically have an access, or do you have to talk to IT to get an access to it and stuff?
No, using a trust email, you can log into it or you can create an account. Okay, and because if you create an account without logging into the trust ID, then it would be a bit difficult. But the trust actually pays for this, so everyone should have access to IRFA. Thank you. Thank you for the time, Doctor.
Thank you.
Thank you very much.
Okay, bye.
Good afternoon, everybody. My name is Alaeldin. I'm one of the administrators in the respiratory. Do you guys link and see the slide? I think if it's moving, there's someone just to share it for me, please.
We can see them moving.
All right, thank you. Right. So today we are going just to navigate together through the interstitial lung disease. I think it is a little bit complex, and but hopefully we'll get something new from the session today. So basically, the interstitial lung disease is part of the restrictive pathology that affect the lungs, and it's mainly affect the interstitium of the lung, which is the area between the alveoli and the capillary. So this is why it results in respiratory failure and high AA gradient when you do a blood gas, and probably resulting in stiffness of the lung and poor compliance. So classifications of interstitial lung disease is quite broad, and there are more than 250 type of interstitial lung disease has been reported in literature. But just to simplify the classification, we got ILD that is related to unknown etiology, and ILD that is of unknown cause. And we all are aware that the known causes of interstitial lung disease can be exposure to organic dust, like birds, hairy mold, or bacteria like mycobacterium, and also probably exposure to inorganic dust like silica, asbestos, coal, for example. Some interstitial lung disease also might be related to smoking, like disquamative interstitial pneumonia, DIP, respiratory bronchiolitis, interstitial lung disease, RBILD, and Langerhans cell histiocytosis, also one of the things that might be related to smoking. Drugs also, chronic use of some drugs might result in lung scarring and lung fibrosis, like nitrofuran, triamidol, methotrexate, and some of the chemotherapies as well, like pembrolizumab. Connective tissue disorders, also one of the known causes for interstitial lung disease, and rheumatoid arthritis, I think scleroderma, one of the commonest one, in addition to dermatomyositis and myositis. The unknown cause of interstitial lung disease mainly is related to idiopathic interstitial pneumonia, and this has two subclasses, which is the IPF, which is idiopathic pulmonary fibrosis, and the non-IPF pattern of fibrosis, which include different forms like acute interstitial pneumonia, which is give a similar presentation like ARDS, and lymphoid interstitial pneumonia could be idiopathic, could be also related to connective tissue disorders like Sjogren's syndrome. Cryptogenic organizing pneumonia, COP, might also be idiopathic, sometimes might be caused by mainly connective tissue disorders or post-pneumonia. And the second common type of idiopathic interstitial pneumonia is the non-specific interstitial pneumonia. We'll see the radiological pattern of each one. So this is again just a repetition of what we got on the previous slide regarding the classification of pulmonary fibrosis and mainly the idiopathic interstitial pneumonia. So we got a terminology, we call it like a progressive pulmonary fibrosis, which is the PPF. And PPF, it is not a district disease, but it is a behavior of the lung fibrosis itself. So any kind of interstitial lung disease might progress to progressive pulmonary fibrosis. And to define that, we need just a worsening in respiratory symptoms. So patient became more short of breath or coughing more, or decline in his exercise tolerance. And this needs to be supported also by radiological evidence that demonstrate increased in lung fibrosis features on a CT scan, in addition to a physiological changes, which is a reduction in the FVC, forced vital capacity, by more than 5% in 1 year, or reduction in the DLCO more than 10% also in 1 year. So any patient that has a worsening respiratory symptoms in a background history of interstitial lung disease, it was to have an assessment if the patient has a progressive disease or not. So, so if we have a look on this CT scan slides, ranging between 2060 and 2022, if we see in the right side, sorry, that one.
Try your response for you.
So yeah, in the right side, we see just along the slide here showed some reticulation of in the lung parenchyma and some fibrotic changes, which has progressed significantly on another CT scan just at the follow-up. The same thing that we spoke about, just to define radiological progression of a disease, you need to have just either increase in the severity of the traction bronchiectasis. Also, if there is increased ground glass densities, or there is an EU ground glass opacifications. Also, just an EU fine reticulation in a CT scan, or increased coarsening of reticulation, and also increase or become more dense honeycombing features, if we see here compared with the previous one. So honeycombing progression and also a volume loss of the lung could be a sign of disease progression. So if we go through the idiopathic pulmonary fibrosis, which is the commonest type of interstitial lung disease that we encounter in clinical practice, this is just a diagram, just a picture showing a cross-section here regarding the small airways, terminal bronchioles, and the alveoli, including the alveolar wall. And we see the normal cross-section view for the terminal airways compared with the distal one, which showed the destruction of the alveolar wall and thickening of the interstitium. And this has been replaced by a dense fibrous tissue due to presence of the fibroblast. This is exactly what happens in pulmonary fibrosis. Just an image for post-mortem lung fibrotic one. So idiopathic pulmonary fibrosis, what exactly this term means. All right, so it is a chronic and progressive disease causes progressive fibrosing interstitial pneumonia, and it is of unknown cause. One called idiopathic pulmonary fibrosis. This is a terminology to describe a progressive lung fibrosis of unknown cause. So the ATS, which is the American Thoracic Society, defines IPF as chronic interstitial pneumonia that is limited to the lung and has a histopathological and radiological features of usual interstitial pneumonia, or UIP. And UIP is a unique histopathology description of IPF that on a lung biopsy. Radiologically, the idiopathic pulmonary fibrosis has a lower loop predominant, affecting the lower loops, and also predominantly affect the subpleural area and associated with honeycombing and traction bronchiectasis. So these are the four main features of IPF radiologically. So the diagnosis of IPF needs to exclude other causes of the same UIP pattern radiological features. So you need to exclude other causes of lung fibrosis, and usually carries just a poor prognosis and sometimes may be worse than some of the malignancies, and the outcome might not be favorable as well. So IPF, as we know, it is unknown cause and common in male compared to females. And in the UK, the incidence around 7.5 per 100,000 of population. And mortality also is high, around 5,000 per year. That is a significant mortality. So worldwide, it is 10.7 cases per 100,000 per year in a male and 7.45 per 100,000 in affecting the females. So if we see the this table, so generally when we see lung fibrosis, we need to know whether it is a UIP pattern of lung fibrosis or that is not a UIP pattern. The typical features of UIP pattern it include just a basal predominant subpleural lung fibrosis, and it is heterogeneous. If we see here, it is subpleural. It is affecting the lower lobes, and there is traction bronchiectasis, and there is no consolidation or ground glass changes. So absence of ground glass changes in the presence of honeycombing, subpleural, lower lobe, and traction bronchiectasis. This is the typical UIP pattern of lung fibrosis. So probable UIP pattern, if you see that image with the same lower lobe predominant traction bronchiectasis, but in absence of honeycombing, this is called just a probable UIP pattern. Sometimes it might progress in the future, but you can't stamp it like a UIP pattern without presence of honeycombing, right? So what are the risk factors for idiopathic pulmonary fibrosis? There are plenty of that. Smoking might be, some cases might be familiar as well and related to some autosomal dominant inheritance due to presence of some of the genes like PERT and MUC5B. These are genes has been demonstrated in some familiar causes of UIP or lung idiopathic pulmonary fibrosis. Environmental exposure also might predispose to that, like metal dust or wood dust, farming. And some studies found GERD has some relation to lung fibrosis. Infection with Epstein-Barr virus, hepatitis C, and adenovirus also might be a risk factor for lung fibrosis. Drugs and radiotherapy, as we said, yeah. So lung fibrosis, how it happened due to, for example, if anyone has a repeated exposure to any inhalation pathogen, this will irritate the lung and cause some inflammation and a release of cytokines and inflammatory products from the cellular component. And this at the end will result in fibroblast and fibrosis affecting the interstitium of the lung. So clinically, we know that exertional shortness of breath is the most common symptom of lung fibrosis. Non-productive cough or dry cough, that is also a feature of ILD. Weight loss due to the hypoxia, fatigue, and due to also hypoxemia and low-grade fever might be demonstrated as well. So examination-wise, the common finding in lung fibrosis in lung we demonstrate like a fine, very bile crackles, to the end in respiratory crackles. Finger clubbing might be evident in up to 50% of people. And in severe cases, complications may develop pulmonary hypertension and cor pulmonale. So generally, the investigation that you may request for any patient who suspect interstitial lung disease, chest X-ray would be the first one to start with. It might be normal if it is an early lung fibrosis, but in advanced lung fibrosis, you might see reticulation or nodular changes. High resolution CT chest being the gold standard test to investigate for ILD general, and just to see the pattern and the extent of the distribution. Yeah. Arterial blood gas, this also is important, mostly will be type 1 respiratory failure. Unless in extreme cases or very advanced lung fibrosis might develop a type 2 respiratory failure, which is a sign of disease or end-stage disease. Autoimmune screening is very important because some of the lung fibrosis or UIP pattern might be associated with other connective tissue disorders like scleroderma and others. So you need to screen them and make sure that the patient is not connective tissue, has no connective tissue disease. Lung function test is a very primary test we can request, and the pattern that you see mostly restrictive defect, and some of ILDs might have a combined obstructive and restrictive defect. For example, that ILD related to smoking might have a combination of obstructive and restrictive pattern. Bronchoscopy has limited role unless you are doing transbronchial cryobiopsy. That is for diagnostic purpose. Sometimes bronchoscopy you may do to exclude other causes, also like infections. Yeah, echocardiogram if you suspect that the disease of progression, and screening for pulmonary hypertension, it would be crucial as well. So if the indication for biopsies in general, if the patient has non-UIP pattern of lung fibrosis, then you might need to do a lung biopsy just to see exactly what kind of disease you are dealing with, because the outcome might be different and the treatment also might be different. So you have a cryobiopsy, right? This is a bronchoscopic cryobiopsy. You pass the cryo probe until the terminal airways, and you get a biopsy from there. And also through thoracoscopy, open lung biopsy. So in the UIP pattern, as we said, we will see just a bilateral reticular infiltrate or pacifications. Ground glass change is not a feature of UIP. So if you see a ground glass in a CT scan, it's unlikely to be a UIP pattern unless there is exacerbation. So it will be like a basal and subpleural predominant fibrosis and presence of honeycombing as well, with traction or without traction bronchiectasis. The second most common type of interstitial lung disease or idiopathic interstitial pneumonia is a non-specific interstitial pneumonia. Sorry, guys. So the non-specific interstitial pneumonia also there will be reticular infiltrates and affecting the lower lobes predominant as well. And there will be like ground glass predominant of pacifications rather than honeycombing. You might see honeycombing, but will be the less dominant. And also there may be traction bronchiectasis. But the most important thing is the presence of predominant ground glass opacifications. So this is another CT scan for a patient with IPF, idiopathic pulmonary fibrosis, and the pattern of UIP. Here we see attraction, lower loop development, honeycombing, and yeah, and subpleural infiltrates. I can't put any traction bronchiectasis here, but it is not a definitive feature for UIP. The most important is lower loop, subpleural, and honeycombing. So this is exactly what you see. It is similar to, it is a honeycombing, yeah. So what about non-specific interstitial pneumonia? This is not my presentation. Sorry guys, it seems that it's the same presentation, but I made some change in the slides. Yeah. So the non-specific interstitial pneumonia, as we said, this is the second most common cause of idiopathic interstitial pneumonia, and it is sometimes may be associated with connective tissue disorders, affect the lower lobe, and if we see that it is sparing the subpleural area, so there is no honeycombing or fibrotic changes at the subpleural area. And predominantly we see ground glass rather than honeycombing. And sometimes you may see like a traction bronchiectasis here as well. So any features like that, also it's worth to screen a connective tissue disorders. What about RBILD, which is respiratory bronchiolitis, interstitial lung disease, and it is a disease of a smoker. So it affects also the young group of people, 30 to 40 years of age, and predominantly cause ground glass changes, and it is upper loop predominant. So it is not a lower loop in this one. So ground glass with some traction bronchiectasis affecting the upper loop predominant in a patient with a significant smoking history. You suspect immediately RBILD. Yeah. And there is no specific treatment apart from stopping smoking. Sometimes the steroid might help to accelerate recovery from the condition, but the most important part is the smoking cessation. DIP, which is discoagulative interstitial pneumonia, also happens in the smoker, and in some people without smoking history might be existing as well. It is similar to RBILD with the predominant ground glass opacifications, but affecting the lower loop rather than the upper loops. So in some occasions, you need just to also exclude other causes like infections, especially in someone with immunocompromised state like HIV, and rheumatoid arthritis, scleroderma as well. Some of the connective tissue disorders might need just to be excluded from the differential. CPFE, which is combined pulmonary fibrosis and emphysema. It is a controversial and poorly defined, right? And it is a smoking-related condition, predominantly causing emphysema in the upper loop, and you notice also fibrosis in the lower loop. Fibrosis might be a UIP pattern or might be also NSIP pattern. There is nothing exclusive for that. But when you see emphysema upper lobe, fibrosis in the lower lobe, so this most likely it is a combined pulmonary fibrosis and emphysema. Also carries a worse outcome and high risk for complications with the pulmonary hypertension and for pulmonary. Right. The more drug-induced ILD is also one of the most important things you need to exclude. Predominantly, it's a history. So if you focus on the history, you might pick up the cause for the lung fibrosis if it is a drug-induced. So methotrexate is a common one, might cause interstitial pneumonia, predominantly causing ground glass changes with maybe some nodularity and traction bronchiectasis, and it affects also the lower lobe predominantly. But to distinguish that, you need to go deeply in the history, especially the drug history. Another drug that might also cause lung fibrosis or pneumonitis, like pembrolizumab. This is a patient being treated for lung cancer, squamous cell carcinoma, in a background history of lung fibrosis. Unfortunately, he developed worsening respiratory symptoms, and on a CT scan, as we see this extensive ground glass changes, and also you will see some honeycombing at the periphery of the lung. But yeah, this is pembrolizumab-induced pneumonitis. So aerospace enlargement with fibrosis, AEF. So this predominantly related to smoking, right? Most likely, it is a part of the entire entity of smoking-related interstitial fibrosis. This is a new term just to describe lung fibrosis, and to distinguish that from the other causes of smoking-related interstitial fibrosis. You will see like cyst, a thin wall cyst, the background history of fibrotic changes, and it is predominantly affecting the lower lobes. So cyst changes with interstitial fibrosis in a patient with smoking, this likely AEF. Yeah. And another thing is predominant, anything that is smoking related is upper and middle lobe predominant mostly. Yeah. So this is a UIP pattern of lung fibrosis in a patient with dermatomyositis and scleroderma. You see the pattern is similar to IPF, which is the honeycombing and lower lobe predominant, but there is a positive autoantibodies for dermatomyositis and scleroderma. So that is a very important part, just to screen patient for connective tissue disorders before categorizing the patient as IPF or not. Another pattern of interstitial lung disease, or like pleuropharyngeal fibroelastosis, PPFE. It is a very just worse outcome of this group of people, and it's characterized by pleural thickening, mostly in the apex of the lung, and sometimes patients might present with pneumothorax. We got a previous patient in the respiratory ward. We presented with pneumothorax, and a CT scan showed features of pleuropharyngeal fibroelastosis. He stayed mostly 2 months in the ward because of ongoing air leak. So a very devastating condition, pleuropharyngeal fibroelastosis. You might see also some of the consolidation, especially in the periphery of the lung, and also some traction bronchiectasis, and honeycombing may exist as well in such condition. But the most important thing is the presence of the pleural thickening. Yeah. So as we said previously, some people with GERD might have some relation with interstitial lung disease, and this CT scan showed lung fibrosis in a patient who has a large hiatus hernia. So progressive pulmonary fibrosis with acute exacerbation. Yeah. What do we mean by acute exacerbation of lung fibrosis? So acute exacerbation of lung fibrosis, it is an acute presentation of respiratory symptoms in a pre-existing lung fibrosis. And this will lead mostly to respiratory function decline and resulted in hospital admission. And the patient may need just an acute care. So criteria to say this is an acute exacerbation of lung fibrosis. Number one, you need a background history of lung fibrosis or IPF and worsening symptoms in the last 30 days in the last 1 month, and presence of new ground glass changes on a CT scan. So presence of the 3 criteria, then you classify this patient as an acute exacerbation of his lung fibrosis. Some lung fibrosis might be related to jobs. So it is very important to ask about social history of the patients. And for example, this is a byssinosis. It's similar. It might present also with heterogeneous fibrosis, honeycombing, and there are some ground glass changes in the patient who previously exposed to cotton. So jobs is very important part of the history you need to focus when you see a patient with lung fibrosis. So to diagnose a patient with lung fibrosis or idiopathic interstitial pneumonia, you need to exclude other causes of lung fibrosis. This is one of the major criteria, like drugs, connective tissue disorders, radiation before, or any jobs related. And also abnormality in lung function test, also just to see a restrictive pattern and reduce gas transfer factor. In a CT scan, you will see some abnormalities like ground glass or honeycombing. And in non-UIP pattern, lung fibrosis, lung biopsy might be needed if the cause is not clear. So in minor criteria, age more than 50, IPF usually. Also there is a progressive symptoms or serious shortness of breath and for more than 3 months, and presence of crepitations, fine velcro, crepitation on the chest examination. So management of lung fibrosis, IPF is generally supportive management. Stop any smoking, or if the patient has any inhalation injuries, you need just to stop exposure to the possible causative agent. Adequate hydration to maintain weight and muscle as well. Immunization to prevent exacerbations, which will result in declining in lung function. Consider long-term oxygen therapy if the patient has persistent hypoxia, and pulmonary rehabilitation also is very important. Steroid has very limited role in managing interstitial lung disease in general, unless the patient has connective tissue disorders related ILD or vasculitis. Sometimes you need to give intravenous pulse steroid if the patient came with exacerbation related to vasculitis or connective tissue disorders. Immunosuppressants with azathioprine or cyclophosphamide. Also, this is not for IPF, it's for other causes of ILD, predominantly connective tissue disorders and vasculitis related ILD. Pirfenidone and nintedanib, these are the two drugs that has been licensed to be used for progressive lung fibrosis and UIP pattern or any progressive pulmonary fibrosis. You need to refer the patient to ILD MDT before get approval for that. Lung transplantation, if the patient is candidate for that. Yeah, so these are just another the list just to a reminder for the other causes of ILDs, which we go through: asbestos, sarcoid, for example, pneumoconiosis, HP. Yeah. So other entity of lung fibrosis or interstitial lung disease, the sarcoidosis. Yes, it is a separate disease that can affect the lungs in different ways. It is a multisystem disease, as we know, that might affect the lungs itself or might affect the lymph nodes, right, the intrathoracic lymph nodes. And diagnosis usually might need biopsy to spread the non-caseating granuloma. The incidence of sarcoidosis ranges between 5 to 40 cases per 100,000 of population, common in black people compared to white people. There is more than a distribution, 25 to 35, more than 45 again. Just in 90% of sarcoid people and 10% of people with sarcoidosis may develop lung fibrosis. Treatment is supportive if it is stage 1 or stage 2, probably. Immunosuppressant might be needed for stage 3 and 4, and the first line is methotrexate in addition to steroid. Yeah, this is just X-ray just to see there is a bilateral dense hilar lymphadenopathy and clear lung parenchyma. So this is stage 1 sarcoidosis. Stage 2 sarcoidosis, as we know, there is hilar lymph nodes or mediastinal lymphadenopathy present in addition to some parenchymal changes or nodular changes, as we see. In stage 3, there is a predominant nodularity of the lung without fibrosis. And in stage 4 sarcoid, as we say, 10% might end up with the lung fibrosis. Yeah. Pneumoconiosis, also this one of the work-related lung fibrosis. And it's due to accumulation of coal dust in the lung tissues. And it's usually related to chronicity, so high concentration for long time exposure. This puts you at risk for pneumoconiosis. And there are 3 types of pneumoconiosis. Simple one is simple coal workers pneumoconiosis, and moderate severity is complicated coal workers pneumoconiosis, and the progressive one, or the severe one, is the progressive massive fibrosis. Usually it happens after the age of 50 years old, and with the lengthy digestive exposure to coal dust. And treatment of pneumoconiosis is also supportive, just avoid exposure and oxygen therapy if the patient requires. So this is just a CT scan to show you how the progressive massive fibrosis look like on the CT scan. Yes,
Just no. Where is chest volume? They might be that side. Sorry.
So it usually present with mass-like opacifications on the lungs with the strand, usually radiating from the with the strand of fibrous bands, for example, likely related to the dense fibrosis. Sometimes this might shrink with time if the patient is stop exposing to coal dust, and Cryptogenic organizing pneumonia, which is another form of idiopathic interstitial pneumonia. It might be idiopathic, but sometimes might be related to other causes like infection. Sometimes you need to suspect organizing pneumonia in people, for example, with the persistent consolidation following pneumonia. So any patient with the features of COP, you need to screen them also for connective tissue disorders and take a proper history, specifically the drug malignancy, and COVID pneumonitis might also be suspected when you see such a CT scan of COP. Yeah, treatment usually with a prolonged course of steroid. We start with a high dose and with slow tapering program. Yeah, and COP is commonly presenting like a ground glass changes, and also sometimes with consolidation-like manifestations. And any patient with non-resolving consolidation, COP should be one of the differential diagnoses. Yeah. You see just a ground glass. Sometimes you see a dense consolidation with air bronchogram. So these classical features of COP. COVID pneumonia might mimic interstitial lung disease and might be similar to radiological features of cryptogenic organizing pneumonia. So you need just to bear in mind to screen patient for COVID if the symptoms are acute. Asbestos also might affect the lung with different ways, but predominantly affecting the lower lobes, and it might present with the similar radiological features of UIP pattern, fibrosis. But if you see lung fibrosis in a patient with calcified pleural plaque like this or pleural thickening, so you suspect at that time, I think asbestos should be at the top of the list of the differential. Hypersensitivity pneumonitis as also is one of the causes of lung fibrosis, and previously known as extrinsic allergic alveolitis. It is mainly caused by exposure to dust and mainly organic dust. Sometimes may be related to chemical compounds as well. The disease may be benign or acute, subacute, and in a chronic disease, it might end up with respiratory insufficiency due to development of lung fibrosis. So, it might be seasonal, as we said, due to exposure to some of the organic dust. Like farmers' lung is about 10 to 500 per 100,000 per year, and pharyngeal lung also is common for people who are bird breeders, for example. Cigarette smoking is considered like reduce the incidence of HB due to downregulation of antibodies response, but it doesn't has any relation to reduce the severity of the disease itself. It's the same pathophysiology for the lung fibrosis. Exposure to allergen also will irritate the lung. If it is acute presentation, it might be confined and it resolves, especially if the patient stops exposing to the allergens. In a chronic exposure, this will result in granulomatous inflammation and might end up with progressive fibrosis. Lots of etiological factors has been nominated for extrinsic allergic alveolitis or hypersensitivity pneumonitis, like people who are in farming, for example, bird breeders, people who are working in textile, for example, plastic, or processing, people who are handling animals, birds, for example, That's very important, just to ask about if the patient has any pet at home, and how close the patient is related to his animals. So that might give a clue regarding the etiological factors of the lung fibrosis. So the common antigens that might result in hypersensitivity pneumonitis, there are plenty of that. Actinomyces, for example, like Tina vulgaris that we found in hay or mold, sugarcane as well, a mushroom that might result in farmer's lungs, Pegasosis, or mushroom's lung. Aspergillus, also you find it in mold and might result in farmer's lung or wood worker's lung. Yeah, a nino lung. That is due to Aspergillus species exposure. Avian proteins from birds, from pigeons, for example, from parrot, that might result in bird phanecia lung. Yeah, so there are many antigens that might be related to hypersensitivity pneumonitis. Acute presentation usually it happens acutely in 4 to 8 hours after exposure. It's just with the prodromal symptoms of fever, malaise, cough, for example, dyspnea and chest tightness, similar to any kind of infection, but it's different antigen exposure. Symptoms usually resolve within 24 hours if the patient stops exposing to the noxious antigen, and commonly misdiagnosed with a viral infection or bacterial infection. So, but sometimes, and examination-wise, you might see, for example, crackles and wheeze. Yeah, radiologically, you might see some micronodularity on a chest X-ray or a CT scan. And the same like any other interstitial lung disease might see like a restrictive pattern during the exacerbation. And histopathologically, you will see just a non-caseating granuloma on lung biopsy. So a micronodularity on a CT scan that might be seen in acute and subacute form of hypersensitivity pneumonitis. Yeah. Yeah, the subacute form also might present with the same, like a dyspnea, productive cough, but for prolonged period of time, and crackles is a predominant features on chest examination, and in addition to restrictive pattern of lung fibrosis on a PFT. Yeah, histologically also you'll find a non-caseating granuloma on a lung biopsy. And the CT scan, you'll find like a micronodularity on a CT scan, and also ground glass opacifications or mosaic pattern on a CT scan, predominantly affecting the upper lobes as well, upper and middle lobes rather than the lower lobe, right? And the treatment is just avoid exposure. That might help. Steroid also might be used just for accelerated recovery. This is a feature of subacute hypersensitivity pneumonitis with some ground glass opacifications affecting the upper lobe predominant. Yeah. So chronic presentation is similar to any lung fibrosis or UIP pattern, usually presented with the progressive respiratory symptoms. Clubbing of fingers, clubbing of the fingers, and presence of crepitation in chest exam. Restrictive pattern may be there as well, and some people might have a combined obstructive and restrictive pattern due to presence of air trapping. And fibrotic part of hypersensitivity pneumonitis may be similar to the UIP pattern with presence of honeycombing of the lung. Yeah, but here the honeycombing will be affecting the upper lobe predominant. Yeah, yeah. So this is a similar thing. Yeah, lung fibrosis. It might be just a combination of honeycombing and ground glass features. So this is just a table just for a comparison between acute, subacute, and chronic in presentation and features. Prodromal symptoms are common in acute form. Dyspnea, all of them can present with dyspnea, and cough is non-productive cough. Sometimes may be productive in acute and subacute. Malaise is common for all types. Weight loss, the features usually of chronicity rather than acute. Crackles is features of all of forms of hypersensitivity pneumonitis. CT scan in acute and subacute might show like a nodular infiltrates and some mosaic attenuation, but in chronic form we find a fibrosis or UIP pattern. It is a restrictive pattern on a pulmonary function test predominantly. So any patient who suspect hypersensitivity pneumonitis, you need to investigate with the chest X-ray, CT scan to see the pattern of distribution, and also just to see exactly what is the cause for that. You need to request the serum precipitins. Serum precipitins, the IgG antibodies for the culprit cause. Bronchoalveolar lavage may be used. Bronchoscopy, it will be like a lymphocytes predominant on the palm, and also a high CD4 count compared to high CD8 compared to CD4 count. And the lung biopsy will show you the non-caseating granuloma. Yeah. Treatment, usually prevention, avoid exposure, and use usually like a protective measures. We're supposed to allergens. Steroids might be helpful, especially in the acute and subacute. Chronic form, usually just a supportive treatment. Sometimes you might need to give antifibrotic treatment if it is a progressive fibrosis. Yeah. Rituximab or cytotoxic drugs might be considered, but I'm not quite sure about the evidence how it is, but it is unlikely to get a good response from rituximab or other cytotoxic drugs. Lung transplantation in candidate people. Yeah. So the progressive pulmonary fibrosis, I think we spoke about this before, and the risk factor for progression is UIP is usually a risk factor for disease progression. Oxygen desaturation during 6-minute walking test. So those patients might progress quickly. Fibrotic hypersensitivity pneumonitis as well, or any patient with a decline in FVC, so that is a real progression. If you find antigen, also that might be a sign, poor sign for disease progression, or presence of genes like MUC5B and TLD gene. These mutations also carries high risk of disease progression compared to other people. And people who has high titer of CCP, rheumatoid arthritis, are predisposed to disease progression and continuation of smoking as well. Yeah. Yeah, so just a CT scan just to see how the disease pattern might change with for a progressive pulmonary fibrosis between here and there. So there is more dense reticulation and subpleural fibrosis compared to the previous CT scan. And here is more clear as well. So treatment of progressive pulmonary fibrosis is by giving the antifibrotic medications, nintedanib and pirfenidone. These are the drugs that has been licensed for progressive fibrosis. It doesn't cure the fibrosis, but they slow down the progression of the disease. So we are nearly there. I think we just go together through this quiz. It will be like three quick questions. So number one is, And at the end of the quiz, we will see the answer. A 47-year-old male with shortness of breath, progressive for weeks. It started around 8 months ago. Also, he has dry cough, weight loss, and his chest X-ray is here. Any comment on the chest X-ray?
It's not good.
Yes.
I said it looks like it's worse on the both bases, but can also see on the upper and both upper lungs. What looks worse on both bases.
Mhm.
It looks like there is a reticulonodular shadowing bilaterally.
Yeah, there's bilateral reticular shadows and some nodularities as well. There are some nodules. Yeah, so his past medical history of HIV, his CD4 count is not that low, 295. There is undetectable viral load. He is on antiretrovirals. He has syphilis in 2009, tonsillectomy. Social history, he works in M&S food factory, denies any dust exposure, is ex-smoker, smoked around 2 to 3 cigarettes per day for 10 years. He keeps 3 dogs at home. He has canaries for years, and he also got 1 parrot. So further investigations, we did a blood test, including autoantibody screening, NA negative, rheumatoid factor is negative, IgM even normal, IgA also, IgG is high, and we did some IgG precipitins for both for pigeons and for parrots, all are high. Any clue? I think it is solved already. What could be the cause? But progressive short of breath, progressive respiratory symptoms, some reticulation affecting the upper lobes, something like that, and some nodularities as well on the chest X-ray. Autoantibody screening are negative, but precipitants, the pigeon, parrots, all are high.
Hypersensitivity pneumonitis, maybe.
Most likely, right? Yes. So this is the CT scan that showed that it's bilateral upper lobe predominant, affecting like ground glass changes bilateral and some mosaic attenuation. You can see. Yeah. Right. So another patient is a 75-year-old man with increasing short of breath, cough, weight loss, and the CT scan. What is your diagnosis? Or what is
Lung cancer.
Oh, brilliant, that's good. Yeah, you picked up a lung mass. Anyone here?
It's bilateral articulation with honeycomb
Lung
appearance.
mass, yeah, right?
Yes, with nodules.
And what other ILB changes on the
Honeycomb
CT scan?
appearance, traction,
Yeah,
bronchiectasis,
yeah.
some dilations, and there is a large mass in the left.
Yeah. The mass there is decimated changes in the upper lobes, and fibrosis affecting the lower lobes here as well. Yeah, in addition to the mass. Yeah, a third one, right, a 72-year-old female with a short of breath, dry cough, smoker. What is the most likely diagnosis?
COPD.
Mm-hmm. Yeah. Emphysema. I can't see exactly emphysema, but they are cysts, right? Yeah. They are pulmonary cysts. In addition to fibrotic changes, there is some honeycombing. Yeah. There's traction bronchiectasis. So So cyst with lung fibrosis. Most likely smoking related, yeah? Smoking related interstitial lung disease. Hypersensitive pneumonitis is a good pick, right? Combined pulmonary fibrosis and emphysema. You see that emphysema upper lobe, fibrosis in the lower lobe, yeah, in the presence of the lung mass. And aerospace enlargement with fibrosis, one of the categories of the smoking-related interstitial lung disease. As I said, it is a combination of cyst in the presence of interstitial lung fibrosis. Yeah. Thank you for your listening. It is a tough topic. Yeah, hopefully you get some clue about it. And yeah. If you need any further, I think the ATS guidelines is a good choice to review. Any
Thank
question?
you.
Thank you.
You mentioned the airspaces. Are we saying that the airspace is sort of almost like bullet, or is it kind of do we need to do further investigation to find what the airspace actually is? Or do we just say it's related to the fibrosis, smoking related fibrosis?
If you find a bulle, for example, or cyst, bulle and cyst is usually, you can see it in a CT scan, especially the cyst because they are quite small. Bulle, you can see bulle sometimes with the chest X-ray if it is a giant. But if you see cyst or bulle, I think the first thing to do is a high resolution CT chest. It will show you if there is any underlying interstitial lung disease or there is any emphysema with the bulla, or that is just ILD with bulla or with cyst, and that's stuff. And it will give you just what exactly pattern of disease you are dealing with. Yeah. Yeah.
Okay. Thank you.
Right. Any question from Lincoln at all?
No.
Yeah,
Thank you.
Thank you.
Thank you. Thank you, guys. Have a good day.
You too.